Thanks for joining us today for a quick update on the elimination of hepatitis C. I'm Tony Martinez, Medical Director of Hepatology at the University of Buffalo. The World Health Organization actually has a target to eliminate Hep C by the year 2030, but to do so, we'd have to reduce new infections by 80%, reduce Hep C-related deaths by 65%, diagnose 90% of all Hep C infected individuals, and then initiate treatment in 80% of all of those folks. Now, there's some new screening recommendations that have been adopted to help achieve this. And these recommendations came about in 2020 from the CDC. And currently, the recommendation is that we screen all adult individuals ages 18 and up. We screen pregnant women at the time of each pregnancy, any individual who may have had some occupational exposure, and those individuals who have ongoing risk factors also need continued surveillance. Now, despite that target, there's only a few states that are actually on pace to achieve it. Most states won't achieve elimination until well after the year 2040. And there's a few reasons for this. Most of the new infections that we're seeing in the United States, and we estimate that there's about 60,000 new cases per year, are tied to ongoing injection drug use and the opiate crisis. If we look at this key age cohort of individuals who are between ages 18 and 29, we can see that as opiate-related admissions increase in that age group, new cases of Hep C go up right along with it. So we've seen almost a 600% increase in opiate-related admissions, and as a result, in this key age group, we've seen new cases of Hep C go up by about 400%. And we know that left untreated, one individual who's actively injecting will potentially infect up to 20 other people within the first 3 years of their diagnosis. So this is a key patient cohort that we really need to get engaged into care. Now, the demographic of who has Hep C has not only gotten younger, but it's also skewed in terms of gender. Now in my clinic here in New York, we see about a 50-50 split between men and women. And if we look at almost a 20-year period, the prevalence of hepatitis C among pregnant women has increased nearly tenfold. If we dial things down between 2009 and 2017, the prevalence has actually gone up 161%, and that represents nearly 5 cases per every 1,000 live births. We have some brand new data that came out that looked at the Hep C care cascade comparing 2019 to 2021. And there's been an increase overall in screening, about a 24% increase, and that's great. The problem is that if we follow that cascade down, there's been a nearly identical 24% decrease in treatment uptake, and that's a critical problem in terms of elimination. Now, there's some barriers that exist that are inhibiting our ability to eradicate Hep C, and I'll walk you through some of them. 31 states still require a prior authorization to get access to medications. We still have 2 states that have fibrosis restrictions in place, meaning that you have to have enough damage in your liver or enough hepatic fibrosis to be eligible for treatment. We still have a handful of states, around 13 states, that have some language around sobriety and the need for abstinence from drugs and alcohol for a certain period of time or engagement in care for addiction disorders in order to be eligible for treatment. There's a handful of states that still require treatment to be done in consultation with a specialist. Some of these states require that you work together with either a gastroenterologist or hepatologist or a provider from infectious diseases. And a lot of states, most states have eliminated that restriction. We also have some restrictions around retreatment. There's 20 states that have some language around retreatment restrictions. Some of these states actually only allow patients 1 course of care. So simply stated, you're not going to eliminate what you're not allowed to treat. As a result, we have brand new data that just came out. And in the United States, only 1 in 3 individuals has been treated and cured for their hepatitis C. Now, if you lack health insurance, it's only 1 in 4 individuals. That key age group that we just talked about, those individuals under age 40, only 1 in 4 has received treatment and cure. And if you're under age 40 without insurance, only 1 in 6 individuals has been treated and cured. This is a very expensive problem. All of these restrictions delay therapy. And what we know is related to some of the economics of Hep C, it's very costly. Just by being chronically infected, individuals cost the system roughly around $22,000 per year. If a patient then goes on to develop cirrhosis, the cost nearly doubles to around $40,000. If those patients develop liver cancer, and we know that with hepatitis C, once you become cirrhotic, you're at risk for HCC, the cost goes up to around $70,000. If you develop end-stage liver disease, again, it's around $70,000. And ultimately, if you need a liver transplant, it costs in excess of $800,000. Now we have curative therapy that's been available since around 2015. And right around the year 2018, these medications actually became what we call cost neutral. They've already saved the system around $15 billion. And we expect that within just the next 3 years, the cost savings will exceed $43 billion. So treatment not only makes rational sense, but it also makes economic sense. It is a bit of an exciting time for hepatitis C in the United States. For the first time in the history of this disease state in the US, we now have an action plan for a national Hep C elimination plan. So this is the first of its kind, and this was introduced in March of 2023. Now, the key highlights of this elimination plan would be to fast track the development of point of care testing so that we could ultimately move toward a test and treat model of care. The plan would also broaden access to curative Hep C medications, primarily through a national subscription model. And it would also provide funding to expand the infrastructure needed to carry all of this work out. Now, this plan is roughly $12.5 billion, but the total cost savings would be around $7.5 billion. So the net spend would be about $5 billion. Now, to achieve those cost savings, however, we'd need to treat more than 300,000 people annually per year for 5 years at least. And that's almost triple what we've been doing right now. So we really need to examine what an effective program would look like. Now, any elimination plan would rely on 4 key pillars: screening, linkage to care, treatment initiation, and harm reduction. And in this case, harm reduction is synonymous with reinfection prevention. Now, the goal is to hit 100% in each of the top 3 pillars: the screening, linkage, and treatment initiation. But when we think about the key populations that are affected by Hep C, those individuals who use drugs, those who are justice involved, individuals who may be unstably housed, or populations that are newly arrived to the United States, or indigenous communities, one size simply won't fit all. And this may take a mixed and match approach. Overall, what we're trying to achieve is a simplified care model of delivery. And we have gotten it down to really few moving parts, and it's become really easy to carry this stuff out. The baseline workup of hepatitis C has really gotten simple. It's just a handful of blood tests. The diagnosis is really easy, and treatment options have gotten easy to use, highly effective with minimal side effects and very few drug-drug interactions. Now, all of this enables non-specialist providers to manage hepatitis C, ultimately decentralizing Hep C management into the community, out of the conventional specialties. And overall, the goal of this kind of program would be to increase screening rates, increase linkage to care, and ultimately result in high rates of treatment uptake and ultimately achieve elimination. So thanks for joining us today. To learn more, please visit chronicliverdisease.org, where there's a wealth of information regarding not only hepatitis C, but other liver diseases in general. Thank you.